Okay, those were great cases, and I'd like to share another one of my ocular hypertensive cases that was perhaps a little bit tricky, and also, though, using the same type of tools and technologies that we've been discussing thus far this evening with our equipment. This is a 36-year-old female. She has a history of high eye pressure and had, at another office, tried topical treatment for glaucoma and failed, and then lost to follow-up care. She has a history of poor follow-up, unfortunately, and also has a variety of other ocular problems that we'll get into a little bit. I think one of the other important things is that there's a negative family history of glaucoma in this woman, and there are not any significant medical history or systemic medications. Her initial visit to the Illinois Eye Institute was in 2017, and her chief complaint was ocular discomfort in both eyes. It had been lasting for several months. There was some dryness and aching in her eyes. By history, she had a sty or hordeola in the left eye. It was previously treated with warm compresses and an oral antibiotic. Again, the history of elevated eye pressure was noted in the history, and as I mentioned, she tried eye drops and then stopped them due to ocular discomfort. She's not taking any ocular medications nor any systemic medications. At this exam in 2017, a chalazion in the left upper lid was identified, blepharitis and meibomian gland dysfunction. Also noted to have anterior polar cataract in the left eye, and she had elevated intraocular pressures at 34 and 36 on Goldman tonometry. There was a small CD ratio and a healthy appearing optic nerve head. Education for all of these issues and appropriate follow-up appointments were made for the patient, and she returned in about a month for OCT imaging. And I'll show you that next with her serous RNFL and ganglion cell analysis there. That shows, pretty robust and healthy retinal nerve fiber layer for the right and left eye. Average RNFL thickness is around 94 microns and 89 microns for the left eye. No other flags on the RNFL quadrant plots or the clock hour plots. The RNFL thickness plots also appear to be relatively normal. A couple of scattered things that you might see on the deviation map. And then really nothing but a tiny bit of artifact perhaps on the ganglion cell for the left eye. So unfortunately, though, the patient did not return for any of other follow-up care, and she didn't return to our institute until 2 years later. And she presented into our urgent care service, again with the chalazion in the left eye, now more uncomfortable, and she wanted it removed. She really had sort of forgotten about the high eye pressure and all the education and information that we gave to her. She had symptomatic dry eye and meibomian gland dysfunction on a more constant basis, and that seemed to be a problem for her. Her intraocular pressure remained elevated from her previous visit in the mid-30s, no other new findings, and she was referred for a glaucoma evaluation prior to referral for the chalazion excision in her left lid. Here's just a snippet out of my electronic health record with her eye pressure and pachymetry findings. So you can see in 2017, she was 34 and 35. In 2019, she was 32 and 35. And then her pachymetry findings are 620 for the right eye and 634 for the left eye.
Michael, could I just ask her gonioscopy? Sure. Do we know if she was an open angle?
Yes, her gonioscopy was done at this glaucoma evaluation, not at the initial one, and her angles were open.
Okay.
Excellent question for somebody with elevated pressure, and any glaucoma suspect should have gonioscopy done. Photos were done in 2019. This is on my previous size camera before I got the Claris, and they're basically just, close-up disc photographs, but they show good, healthy disc appearance, retinal nerve fiber layer, sharp disc margin, small cupping in each eye. Nothing really significant there, I think. We took a picture of her congenital cataract in the left eye, just to document that and, maybe consider how that might affect her OCT or visual field or visual symptoms, things like that, which it really wasn't. These are her first visual fields, CETA faster, but the regular 24-2 pattern. You can see, you know, probably pretty typical first-time test taker results. Shalini, would you say?
I agree. And, you know, again, I always do find that there can be some drop off, you know, when we go from the right eye to the left eye, just as one fatigues. And then, of course, the first thing that I always look at also is, you know, lid position on a patient, if there's any dermatochalasis, ptosis, and, you know, potentially repeating the testing with the taped lid. And if you've done a CETA faster, well, you don't feel so bad bringing them back a little bit quicker to tape the lid and repeat that test.
Exactly. So one of the other tests that I use fairly regularly is corneal hysteresis. You know, it's sometimes a game changer, sometimes it's just additional information, sometimes it's confirmatory, sometimes it's a helpful predictor for what might happen in the future. High hysteresis values over 11.5, over 12 generally suggest a lower risk of developing glaucoma, and that's what the ocular response analyzer found here for this patient. There's a number of other IOP measurements that this will obtain for you in addition to the corneal hysteresis finding. That's the primary data point that I use for the Aura instrument, but you also get a IOP-CC, which is the corneal compensated IOP, supposed to be a more accurate, more true reading, taking into compensation the corneal biomechanical factors that are integrated into the hysteresis property, which is sort of, you know, that elasticity ability of the cornea and therefore the lamina curvosa to deal with elevated intraocular pressure. So it's a supportive finding along with the thick pachymetry to suggest that maybe this patient is at low risk for glaucoma. That's why I included it here. But for discussion points, so a 35-year-old, pressures in the mid-30s, you know, a couple other things going on ocularly. What would some recommendations be in terms of, you know, treatment plan? And
Sure. I would think, you know, one of the first things that I would consider in this non-compliant patient, I mean, thankfully, we're still dealing with, at least based on that OCT, pretty healthy optic nerves. So, and I mentioned the gonioscopy part, you know, first thing that I would consider would be SLT, selective laser trabeculoplasty, in this patient, and see if we could get a response, you know, especially with the LIGHT trial that just came out last year, supporting, you know, the use of the of laser as even a first-line treatment that many of us were doing, but even giving more credence to that. You know, this might be a great patient, a great candidate for first-line treatment.
I think that's a great consideration, and I have that point on a slide coming up. I wonder in a 35, 36-year-old, is SLT always the most effective way to go? And sometimes I find that, you know, SLT is not as effective or as long-lasting in those younger patients, but.
That's a fair point. Still, I do find that, you know, again, where is our target pressure? Depending on if we get her even to mid-20s. I believe the corneal thickness was in the 600s.
Yeah, so like 630 almost. 600.
Yeah, so I mean, we don't necessarily need to get pressures that are in the teens. It could be mid-20s, and that's sufficiently low. And you know, we're moving to an era where there's intracameral medication injections. So as we make progress in that arena, there might be an opportunity to at least do a laser for now, and as things improve, in that might be options in the future for some of our non-compliant patients. I mean, I do find that glaucoma, sometimes it's all about buying time. So if we have buy time until the next innovation.
You're exactly right. To, you know, just do a quick summary of the next few months of this patient from last year moving into this year. We did first start back with a trial of latanoprost. That's what the patient wanted to try first. There was a decent initial response into the with IOP in the mid-20s, but again, she had tolerability issues. Now, probably that's because I overlooked the things that I preached everyone else not to do, which was overlook the treatment of her dry eye symptoms. And, you know, probably needed to tackle both problems at the same time, or at least get my cornea colleagues and my dry eye colleagues involved in that. So anyway, she ended up discontinuing the prostaglandin analog. We did the dry eye evaluation. That sort of went back and forth for a couple months. 6 months later, she comes back in, and I wanted to repeat the visual field test again with the 24-2C and the See to Faster algorithm. I felt more comfortable repeating it more quickly. And what I think is, at this time, was thinking still sort of a high-risk patient with pressures in the mid-30s and low 30s. And I think the results for the right eye and left eye here are still, we're settling out her test performance. Maybe there's some early stuff in the left eye, maybe not. But we need to build that baseline of 2 tests and then look for any change over time with the progression analysis. And I also repeated the OCT in 6 months, which is something I don't typically do. I mean, if you have a good OCT, but sometimes I just, I'm not confident I got a good result, or, even with a high signal strength or
I think I found, even sometimes I've had some patients that acute angle closure, and you do that OCT, it might be normal, but then 6 months later, a year later, all of a sudden you see that drop off. So I agree with you that there was some value in doing that, especially because she's had this consistently higher pressure. Sometimes it takes time for the test to catch up with the damage that's already occurred. So I think that was an appropriate thought to have in repeating my OCT.
Great, thanks. Right, not typical in all patients, but in those, strange patients. So, we talked about other medications. We did talk about SLT. Her IOP fluctuation remained from the mid-20s when she was able to tolerate. We tried bromonidine for a bit. We even tried timolol. Right now, she's on no medications, and her pressure's still at 31.
Okay.
Let me show you the most recent. This is from earlier this year in 2020. Her wide field Claris photos, her close-up Claris photos, and even closer up Claris photos. Visual field test number 3 coming up. Went back to just the 24-2 pattern, and she had a bad test day, I think.
Yeah.
When you put it up on the progression analysis, it just doesn't sort of make sense with everything else.
Right.
OCT, this is her 3rd OCT now. The first one was in 2017, and then 2019, and then again in 2020.
Yeah.
Is something starting there inferiorly in the right eye, in the ganglion cell region? Maybe. Here is, and we can do her GPA analysis for the right and left eye and the RNFL. And it's actually, if you go by average RNFL thickness, pretty steady.
Yeah, especially since you've got, your baseline from 2017.
Yep. And then we have our ganglion cell GCIPL GPA.
So, I think there are patients that sometimes are just ocular hypertensive and then don't convert. And you're doing all the right things, which is just continuing to follow, monitor, and collect the data. And if she does develop a change, then you're going to intervene. But it is a thought to potentially, offer SLT. I do think that, now that we can offer the light study data, patients seem to, when I tell them, when they looked at outcomes and then patient satisfaction at both the laser versus the drops, it's pretty much the same. And I tell patients that it's done on a routine basis, and no patch, no shield afterwards. So I think it seems it's all about how we present it. And I think when patients hear laser procedure on my eye versus, I can do an eye drop, more often than not, they're going to say, I'll do the eye drop. But if we present it in a way that this is a procedure that I do routinely, and most patients tolerate it without any issues, and I feel very confident about the results, and we have data to back this up, then I think they may be open to it. And I think sometimes the younger patients might be more open to it as well.
Yeah.
So
especially this woman that had such difficulty with topical medication.
Correct. Correct.
And
correct.
even though we're working on her dry eye and everything, that's a real difficulty. And you referenced the Duresta, the bimatoprost.
The Bimatoprost. Yeah, it's released. Yep.
Yeah, And so that might be, something we consider on her in the next 6 months or so as we get more involved with that.
Yep. I think that would definitely be a good consideration in a non-compliant patient like this, or one that is not able to tolerate the medication. So,
Yep.
Yep, there's a lot of great options for her in the future.
Great. Thanks for your input there. That helps a lot.
Okay, so thank you, Michael, for sharing that interesting case management case that you had. And I thought we were going to end today with a couple cases of, kind of outside the box of our typical glaucoma patients, just thinking of other reasons to be for treating and how we manage those patients. So not infrequently get referrals and for abnormal testing. And in this case, this patient, a 70-year-old white female who's referred for glaucoma evaluation with an abnormal OCT and borderline pressure in the low 20s, history of hypertension, hypothyroidism, arthritis. She hasn't had any history of surgery, laser, or trauma. She does have a family history of glaucoma, in her grandmother. So you can see that it's red on the OCT, on the deviation map. And you can get the impression that there might be, diffuse thinning in both eyes here. And we did, a visual field test. Unfortunately, that looks like there's significant general depression and an inferior nasal step, as well as an inferior arcuate in that right eye. And then the left eye, see some circumferential defects. These are her optic nerves. You see kind of like a small crowded disc, but very concerned about the OCT and these visual field defects. Her pressures consistent with what they were before, low 20s. Thankfully, her vision is 20/20 in both eyes with some mild cataract changes. So, Michael, do you tend to get some referrals with these abnormal red disease kind of patients?
A lot.
Yeah.
Because people always believe what the OCT tells them, and that's just not the case.
Right.
And it's a perfect example of having to have a good view in the back of the eye, a great photograph, and know that everything is not glaucoma in the back of the eye.
Right. And red does not mean that this is glaucoma and we've got to treat.
Yep.
So I'd like to go back, if we can, to the previous OCT. So if you can see that actually if we look at the tomogram, you can see there's kind of this irregularity. It's not the typical concavity that you see with the optic nerve, and
looks bumpy.
Looks bumpy, exactly. The perfect technical term for that, bumpy. So if we go forward, basically, when we looked at the optic nerve, that crowded disc, it was more suggestive of potentially buried drusen. So, we ordered a B scan, and you can appreciate that lighting up the drusen where the optic nerve insertion is consistent with the buried drusen. And, I did end up repeating the OCT outside. That's the other thing to do. Whenever we get a referral, it's always important that, you repeat the testing so you don't know the quality of the testing, and just to get another baseline, as Michael had suggested previously when he's been doing his OCTs, even to see, is this really there's change or are things stable? So in this repeat one, you can see that there's a little bit more normal looking optic nerve in the left eye, not all that red thinning that we saw in the initial OCT. And then we did a follow-up visual field. And in this case, I was able to do the CETA faster, which, in patient with optic nerve head drusen, we do want to really look at those central points as well to see if there's changes. And you can see that the right eye does have those inferior nasal defect, inferior arcuate changes, and then the left eye has some inferior non-specific changes. But even though this patient has optic nerve head drusen, does not preclude them from getting glaucoma. So we still need to follow these visual fields and see if there are changes over time, because they could have concomitant disease processes going on. So again, this is the CETA faster, gives us those central points as well. And just to always think, red does not always mean glaucoma. Think about other things that could be causing, especially when you're looking at those nerves and thinking, gosh, those are not cupped out optic nerves. That doesn't make sense.
Right.
And go back and look and see why you might be having, red disease, but not necessarily the same clinical picture to go along with it. Michael, do you have any other thoughts on
No,
that?
these are, like you said, these are tricky and sometimes difficult patients. And the key take-home messages is get all the data. Sometimes don't act too quickly. Reconfirm the data, and make sure you consider other possibilities besides glaucoma. Great case.
Right. Yep. I agree with you. Reconfirming, repeat testing is always key too. Okay, we have a second case here. This is a 78-year-old African-American female who's being followed for glaucoma in the right eye greater than the left. She has a history of high pressure in the right eye, 37, thinner corneas, and an enlarged nerve in the right eye, about 0.9. The left eye, thankfully, has been pretty healthy. She's undergone cataract surgery in both eyes and trabeculectomy surgery in the right eye due to that advanced glaucoma. And these are her optic nerves and the fundus photography. And you can see that because of the peripapillary atrophy, this is going to affect some of the imaging testing. And the right eye is consistent with how I described it, with pallor, 0.9 heptodisc, and then a more moderate, healthier looking nerve in the left eye. So did OCT testing on her. And in this kind of patient with that significant peripapillary atrophy, you might not get the best image. So in this case, OCT might not be my go-to image to follow her. Do you find that too, Michael, sometimes that there's some of your patients that you're just maybe relying more on visual fields or
especially
photography?
At the end stage of disease or other patients with high myopia, the OCT just doesn't give you what you need to find and need to follow. So it is definitely visual fields when you can get it.
Yeah, and going back to, your fundus photography that you were discussing at the beginning of our discussion, These are the patients that, okay, you did the fundus photography several years ago, and now let's take a look and see if there's really been change or not. And OCT is not going to be the answer. So another, support for that. So I went ahead and, did her annual visual field test. And this was in 2019, severe depression in that right eye, probably at this point should be converted to a 10-2 in that right eye. And then the left eye showed an enlarged blind spot. And this year we went ahead and she came in to do her visual field testing. And I did the CETA faster. All of a sudden now we see a significant decline in that left eye. And again, this patient's monocular. She's relying on that right eye. So this is very concerning as to what is going on. So Michael, the first thing you would probably do is repeat this and
go back and look at the patient and make sure that I have a reason for why that change came up so quickly in the patient. So consider other possibilities.
Yep, absolutely. And that's the perfect answer. So, repeating would be the one. Oftentimes if patients have dry eyes, that could be an issue. I mean, that's like the most common reason. So the first thing I kind of look at is, like you said, looking back at the slit lamp, the clinical exam, the cornea, is it clear? Did the patient have significant punctate epitheliopathy? Do they just need to have, a month of artificial tears come back and we repeat the visual field? And not infrequent where I see a sudden improvement. This patient was pseudophakic, so it's not a cataract, but I did notice that she had developed a significant secondary cataract. And, the rest of her clinical exam, when I looked at her optic nerve, it looked pretty healthy still. So when I instead of having her come back to repeat the visual field, I decided, let me go ahead and do the YAG capsulotomy. And then thereafter, I went ahead and did the repeat visual field, and look at that, success.
We do that in glaucoma all the time, right?
I know. Wouldn't that be wonderful?
Better.
yes. So she's happy. Clearly much happier. And again, the key is repeat testing, look back at your clinical exam, and go from there.